Welcome to today's presentation. My name is Corinne Young. I'm a nurse practitioner in pulmonary medicine. I've been in pulmonary for I'm over 20 years officially now, and I will be talking to you about mainly the pulmonary pieces of what we're going to be talking about today. And also joining me.
So hi, I'm Wendy Simmons. I'm a physician assistant in Wilmington, North Carolina, at a rheumatology practice. I've been there 28 years, and my relationship here is I've worked real closely in our town with the Pulms and established multidisciplinary discussion clinics with our colleagues. So I'm excited to present with Corinne today as well, and I'll be doing more of the rheumatology serologies.
We like to order serologies in pulmonary. We just don't like to talk about what they mean. All right, so here's our disclosures. Wendy's a little busier than I am, it looks like. All right, our objectives today to describe the relationship between interstitial lung disease and connective tissue disease, including the impact of systemic autoimmune rheumatic disease, ILD. If you previously knew this as CT-ILD, you are now OLD because they keep changing terms, and if you stay in medicine long enough, you're going to keep getting it changed on you, so get used to that. We're also going to talk about current diagnostic treatment strategies for ILD and analyze emerging therapies for ILD and clinical trial data. All right, so this is our agenda for today. In case you didn't already know, we're going to try to get through these. We do have a lot of slides to get through, so I'm going to try to get that through quickly for you, and then you'll go to your breakout sessions. If you don't know which breakout room you're in, if you ask the staff at the back, they will help direct you. Some of you will be staying in this room with Wendy and I. All right, so interstitial lung disease, there are more than 200 interstitial lung diseases. And if you like to treat interstitial lung diseases, you must also like living in the gray, because there's more gray about ILD than there is black and white. I love black and white, I love rules, and ILD does not follow a lot of them. These patients look like all of our pulmonary patients. They're short of breath, they have coughing, which could be a million and one things, but these patients do have these very vague symptoms. They also have a lot of fatigue and decline in their exercise capacity. They also tend to have some overlapping other pathophysiology related to that inflammatory process that is driving their ILD. So there's also a progressive phenotype of interstitial lung diseases that does cause worsening symptoms over time, and we're going to spend a little bit of time on what that progressive phenotype of pulmonary fibrosis looks like and how we diagnose it. So this is a little older data from 2019 with a prevalence of over 500,000 people diagnosed in the US with interstitial lung disease. This number is likely higher, especially after COVID. With the Delta variant, we saw a lot of ILD, a lot of fibrotic lung disease associated post-COVID. The highest prevalence is in the older populations. We tend to see it more in males than we do in females, but just by a little bit. It really likes, especially specific types of ILD, do tend to like white males over the age of 65 who have some sort of exposure in their lifetime, which we're going to talk about, usually occupational or smoking history. When we look at the gender, age, and pulmonary function index, where patients are diagnosed at stage 1 versus stage 3, this does show that their 3-year mortality is not exactly what you'd want to see. And the big point of this data is to reflect that time is long. Lungs are very delicate, they're exposed to the world, and unfortunately a lot of damage cannot be undone when it comes to fibrotic lung diseases especially. So there's about a 50% mortality in 3 years for these patients if they're left completely untreated. We used to, unfortunately, a lot of our patients who end up with interstitial lung disease diagnoses will go online, they'll look up a how long do I have to live type question, and they'll see that 3-year graph that shows that they're going to be dead in 3 years. And one thing hopefully you'll be able to talk to them about is don't Google, please, and 2, you know, this is for patients who don't have any treatment options. And up until 2015, we had very few treatment options for ILD patients outside of immune suppression. And some of our therapies even killed them faster. So we do have better therapies now for them. So in pulmonary, when we are getting patients with interstitial lung disease, we are often working backwards and with trying to figure out what caused it. Is there any other underlying diseases related that could be causing this interstitial lung disease? Whereas rheumatology, you guys have a little bit of a crystal ball, because they've got scleroderma, they've got rheumatoid arthritis, or something that could potentially develop into pulmonary hypertension or interstitial lung disease, right? You guys are kind of screening and looking, and oftentimes the first time a patient knows they have an autoimmune disorder is when they've been diagnosed with an ILD. So we're working a little bit backwards. So first thing we try to do is figure out, is there something that we can say caused it? And that's where some serological assays come in that Wendy's going to talk about. And then we start looking at the morphology of it. So at our fingertips, what do we have? Imaging is very important to us in pulmonary. We rarely biopsy these patients anymore. And I'll talk a little bit why we don't biopsy them as often. So sometimes we'll have a bronchoscopy if it looks like it's an infection that's not resolving. A lot of organizing pneumonias are non-infectious pneumonias that are interstitial lung diseases, and we may do a bronchoscopy to make sure there's not something infectious that's driving it for them. And then surgical lung biopsies are fewer and farther between, thank goodness, for poor patients, but occasionally that is still done if we just can't find, if we need to know for whatever reason exactly what kind of ILD it is, and even then sometimes we don't get an exact answer. And then the behavior of the disease. Is it stable? Is it improving? Or is it progressing? And we measure that by their lung function, the forced vital capacity. Forgive the one, I don't know why that's there. I think they were kind of combining FEV1 and FVC, but the forced vital capacity is the FVC, DLCO, which is the diffusion capacity of carbon monoxide, and then the 6-minute walk test. And if those are declining over time, and we'll talk about what percentage of decline we consider significant, that's telling us this is a progressive phenotype of lung disease. All right, so when we first look at the etiology, this is a very simplified look at the classifications of interstitial lung diseases. Have you guys all seen that interstitial lung disease tree? I see a lot of nods. If you haven't seen the tree, BI has this amazing interstitial lung disease tree, and each limb tells you these are smoking-related ILDs, these are autoimmune-related ILDs, these are drug tox ILDs, and it kind of helps you really understand what family that patient is belonging to. Idiopathic pulmonary fibrosis is one of the deadlier ones, and also one of the ones that patients are going to bump into online first when they look up interstitial lung disease or pulmonary fibrosis. This is the one your patient's going to see, even if it's not the disease they have, it's what they're going to be exposed to the most online. It's idiopathic. We don't know what causes it. And so patients always want to know why, and we just tell them, we don't know yet. Systemic autoimmune rheumatic disease associated with ILD. This is the old CTD ILD, is now SARD ILD. Hypersensitivity pneumonitis. This could be hypersensitivity to molds. This could be what we call like hot tub lung or sauna exposure. Even patients exposed to like wood reeds and wind instruments, like the moisture in the reed. The feathers, bird fancier's disease, sometimes we would call it. The feather in down pillows or down comforters, down jackets even. We had a patient who kept having HP, and we found out it was a feather antigen. He had no birds in the home. It was his down jacket. So those things can happen with hypersensitivity. That can progress to a fibrotic phenotype as well. And then drug tox. In pulmonary, we hate amiodarone more than anything. Next to amiodarone, we hate macrobid the second, because we end up with some drug toxicities with interstitial lung disease related to those therapies. There is pneumotox online. If you guys haven't looked there, you can see if maybe some drug toxicity may be coming from a therapy that the patient's on. And oh, by the way, all of our lung cancer patients are now getting CHEK2 inhibitors, which also tend to cause pneumonitis in the process of trying to battle their lung cancer. So we get a lot of drug-induced ILDs as well. As far as infectious disease, associated ILDs, these are more the viral infections. And pre-COVID, we would see these influenza pneumonias that would leave behind fibrosis or permanent damage of lungs. And now with COVID, again, Delta variant was the worst. It's been getting a little bit better. We still have patients that end up with organizing pneumonias even after COVID pneumonia. So that's something that we're always looking for. And again, we want to make sure we're identifying them as early as possible. Don't ignore a CT describing any interstitial process. Make sure that they're getting to your pulmonary colleagues or getting repeat imaging at the very least to make sure that this is not the beginnings of something that can turn into something very bad for them. As far as what ILDs you're likely to bump into, most common being IPF, and then the autoimmune, you likely are going to see more of the autoimmune. And then the hypersensitivities, just kind of break down there. So serologies, I'm going to hand over to Wendy.
Thanks. So, here we are in rheumatology, and, our job is to obviously help our Pulm colleagues figure out the picture. We love to do labs in rheumatology. We also want to be sure we're getting our stethoscopes out, we're listening to the chest. We see a lot of autoimmune diseases that can help pulmonary find interstitial lung disease as well. We do a lot of labs. As Corrine said, time is lung. Baseline ANAs, ANA panels, if we have any suspicion in our patients, the anti-CCP, rheumatoid factor panels. Recently had a patient sent from pulmonary to me in the past few weeks, and the patient had positive CCP, positive rheumatoid factor, and then the patient ends up in my clinic. I see the patient, and the patient is like, I don't know why I'm in an arthritis clinic. So, a big part of our job is educating our patients, but also in our clinics paying attention to what we need to do to help pulmonary in either expediting through with labs to maybe get more specificity as to which autoimmune disease that they have, maybe also pre-order some tests with pulmonary function, DLCO, the high resolution CT, and be able to expedite them to pulmonary. Certainly we see a lot of rheumatoid that is really high on the list for interstitial lung disease. With these patients, lupus, Sjogren's. The Sjogren's is a disease is big now. We're learning more. We should have been learning more in the past. These patients with mixed connective tissue disease, anasynthetase syndrome as well, scleroderma. We have patients in our clinic that we're seeing with scleroderma, and these can be really tough patients. So, getting the antibodies, being able to help figure out the picture as well, certainly is going to help our Pulm colleagues. The continuation of the etiology and morphology, as Corrine was talking about, different patterns with interstitial lung disease. Radiologist certainly helps that when we're ordering our imaging studies, maybe before we get them to Pulm, but we're also following these patients along the way. We're seeing them for their autoimmune disease state. We're also sharing medications. So these patients might be coming back to our clinic with acute exacerbations. So it's important that we learn the ongoing pulmonary fibrosis and how that can continue even if we have the autoimmune disease under control in our clinic. Say if that patient has RA, they're in our infusion suite. We want to be astute to understanding what we're going to pick up for signs or symptoms of acute exacerbations so that we can get that patient back to pulmonary. Also, our patients in rheumatology, they often have more than one autoimmune disease. The autoimmune diseases travel in packs, so we want to be continuing to evaluate those patients as well, understanding what medications that we're using along with pulmonary to be able to treat that patient. But you do see the interstitial pneumonias, the nonspecific interstitial pneumonias, and you see really how our ILD shows up in several of these, scleroderma. Those are the important diseases that we need to help our pulmonary friends understand as well. Corrine's going to go through our imaging studies and some other studies as well.
Thank you. All right, so you guys might see UIP mentioned, UIP pattern. Think of that P as pattern, although it's technically pneumonia is what they're calling it, but that P is the pattern, it's not the diagnosis. So you might see in your imaging report, if you're not looking at the images yourself, a UIP pattern, and as Wendy was showing you, UIP could mean any of these things. Unfortunately, it really doesn't tell you what it is. So that just is telling you that there is this pattern that is specific to diseases that follow, that kind of fall under that pattern. For UIP, generally what they're talking about is oftentimes basilar predominant. So just in case you don't look at your CT imaging, can I move this with me? In case you don't look at your CT imaging, I'll try to do this on the other side too. We tend to see basilar predominant. So this is the chest here, this is the spine here, this is right lung, this is left lung, this is the beginning of the diaphragm, so we're at the very bottom of the lung. Up here, I don't know if you can appreciate from how far back you are, it's pretty smooth. This should just be a black line between where the chest meets the chest, I'm sorry, the lung meets the chest wall. And then it starts getting very lacy and rough appearing. That reticulation can turn into fibrosis, honeycombing with patients. But we tend to see this basilar predominant pleural base disease. When we're talking about a UIP pattern, it can climb up the sides of the lungs and start invading upper lung areas, but oftentimes will first show up in the bases. With NSIP, it's non-specific. It can look like a lot of different things, but usually one of the hallmarks of NSIP is it's a combination of both ground glass and fibrotic changes or coarse reticulation along with ground glass. So ground glass is really anywhere where it kind of looks like somebody smudged chalk, for those of us old enough to remember a chalkboard. Not everybody had that. Whiteboards now and smartboards, but it kind of looks like smoke or smudging, kind of appearance with this coarseness of the interstitium appearance. And this can happen in different areas of the lung, but also can happen in the bases. Specifically, you can have bronchiectasis with either of these areas, either of these disease states. Organizing pneumonias, again, depending on how old you are, we used to call it BOOP, and then it was COP. Now it's COP, cryptogenic organizing pneumonia. And there's several other types of organizing pneumonia that are idiopathic interstitial pneumonias is another term you might hear for them. Basically, they're non-infectious. They are inflammatory pneumonias is how you want to think of them. And they can happen pretty much anywhere in the lung. Also, oftentimes you will have consolidations that look like pneumonia. So you'll have a patient say, I've had pneumonia for 6 months. I'm sorry, what? Nobody has pneumonia for 6 months, or you're dead, right? And so what do you mean you've had pneumonia for 6 months? Well, they keep doing these x-rays and I keep having these, they're not gonna call it infiltrates, but I keep having pneumonia. And sometimes they'll be waxing and waning infiltrates. They keep getting antibiotics. Occasionally someone will give them a steroid and they feel better. And then it comes back and it keeps coming back. And they really don't have infectious symptoms. They don't have fevers. They don't have hemoptysis. They don't have, been hit by a truck kind of symptoms that you would expect with an infectious pneumonia. That's often a hallmark to us. What do you mean you've had 7 rounds of antibiotics and your pneumonia is not going away? Those are patients that may get a bronch to make sure that it's not infectious. But usually those organizing pneumonias are inflammatory pneumonias, which oftentimes, luckily, can be reversed, and patients can go in complete remission and end up with oftentimes no permanent damage. DAD, diffuse alveolar damage, we're going to see usually hemoptysis in these patients. We're going to have a lot of ground glass, so it's all kind of whitish here, and then you're going to have some, because it's an interstitial disease, you're going to have all these interstitial infiltrates happening throughout. And then the last one is the hypersensitive pneumonitis. Usually, and I wish they had a little better picture here, but usually it's a mosaic pattern. So are everybody familiar with mosaic type art, with tiles and things like that? So you'll have an area of density next to an area of hypodensity, and they're all kind of patched together in these segments. And that's oftentimes a hallmark sign of hypersensitive pneumonitis. Sometimes your radiologist will call it out as mosaic pattern, which could be air trapping, which it is air trapping generally, but oftentimes there is air trapping. It's not necessarily that air is trapped, making it hypodense. It's that there's ground glass disease, making the hyperdensity areas contrasting to really the normal lung areas that are not affected. All right, so histopathologically, you can also have this UIP pattern. So again, UIP is not the disease, it's the pattern that we're seeing either in radiology exams or in their pathology results. Now, oftentimes when we are doing biopsies on this patient, when we're doing a bronchoscopy, it's all of the tissue that we can fit inside the head of a needle, right? We're going into the airway, we're sticking the needle through the airway to try to take a core sample of whatever we can get without causing a pneumo and hemoptysis and all that great stuff. So we're not getting a whole lot of chunk of tissue. Open lung biopsy is where they get a thoracotomy, and they usually take 3 different areas. They get it, we collapse their lung in the process. They've got chest tubes. They're in the hospital for several days. Hopefully, they reinflate great. They don't have an air leak, and they go home. So very, very invasive for these patients, and oftentimes would lead to exacerbations of their interstitial lung disease after poking and prodding them. So if you do happen to get pathology on these patients, these are the different findings that you'll have. looking at these patients' pathology. Okay, so when we are looking at acute changes in our patients, oftentimes we're going to see more ground glass in acute disease. That inflammation is often acute. It takes time to really scar and fibrose the lung. Not very much time, but it does take time, just like you guys see with arthritis, right? Initially they may have pain and swelling, but they may not have joint destruction yet. That inflammation is bad regardless of where it occurs. We are going to talk a little bit more pathophysiology, and we're going to have a little bit of A&P a little bit later, talking about where the interstitium of the lung is and where this inflammation takes place. But the chronic inflammation in those areas then cause problems, just like in the joint space, and we end up developing fibrotic disease. And I tell patients, you can't unscramble an egg. So once that fibrosis is there, we can't undo it as of yet, unless they're going for transplant. So the inflammatory mechanisms that push the inflammation in the lung are pushing that inflammation other places in the body, and especially the patients with the autoimmune related interstitial lung diseases, we usually are also going to see some flaring happening simultaneously in their other areas. All right, so in our idiopathic patients, although we don't know what causes it, there tends to be some family history sometimes. Oftentimes male to male is something I see very commonly. My dad had it, now I have it, I'm a male, so we kind of see that, or my mom had it, and my other siblings also have it. So getting that good family history in your patient is very helpful. Environmental, again, a lot of times these patients have exposures to cigarette smoking or occupational exposures where they're working with chemicals, fumes, powders, things like that. And this could be decades ago that they had this exposure. They haven't smoked in 30 years, but they tend to have that history backing them up. And then behavioral histories, which I think kind of goes with the smoking history as well. All right, so here's our little pathophys here. So when you think about simplified version of the lungs, they are straws with balloons on the ends, right? So we've got the airways, which are the straws, the balloons, which are the air sacs. The alveoli are elasticy, they're stretchy, and they're surrounded by a fishnet of capillary bed. And that's where the magic happens and gas exchange happens to get oxygen into the blood supply. Well, the tissues between are the interstitium. So it's kind of the glue that's kind of holding everything else together. And that interstitium needs to be very thin and very compliant for the lungs to work like they should and to be able to exchange gas. And what's happening in these patients is that there is this inflammatory process happening in the interstitium. You guys can see over here, like in this space here. And I know it's very hard to see from very far away, but it's talking about fibroblasts, which are normal circulating entities that we have. These fibroblasts, TGF-beta and microfibroblasts, they're in circulation, but what happens for whatever reason is there's some sort of insult that turns them on and then starts creating fibrosis in this space. And that then leads to thickening of the interstitium for name your reason. Again, it could be the parrot they have in their house. It could be the autoimmune disease that's flaring or not well controlled or not identified yet. It could be, again, idiopathic. We don't understand about genetics yet with IPF. And then as that interstitium thickens, a couple of things happen. One is it becomes too dense for gas to exchange in those capillary beds. Another thing that happens is the lung loses its elasticity and compliance, and so it becomes stiffer, and it's not able to take the volume of air into those spaces, into the alveoli like it has been designed to do. So, progressive pulmonary fibrosis. So this PPF is where a lot of the research has gone over the last several years. How we define PPF, progressive pulmonary fibrosis, and this could be any underlying interstitial lung disease, okay? Hypersensitive pneumonitis can develop into a fibrotic phenotype. NSIP can progress into a fibrotic phenotype that can be progressive. IPF is generally progressive. So how we know it's progressing is we're watching their FVC. Again, forget about the one. We're looking at their FVC and we're looking at their DLCO, their diffusion capacity. And if their FVC declines by 5% or more in 12 months and or their DLCO declines by 10% or more in 12 months, we consider that a progressive phenotype. Another way that we also look at it is the radiology findings. So I'm in a community setting. I'm not at a university setting or an ILD center. You guys have, by the way, some amazing pulmonary APPs here that are going to be in your workshops that are at big, like Cleveland Clinic's ILD Center and National Jewish and all sorts of great places. They do practice a little differently than community practice, only because we don't have as many resources as they do. In community practice, we repeat CT imaging for worsening symptoms and or lung function. So just so you know, if you're not working with a big system and you have a community pulmonologist that you're working with, they may not be getting serial imaging just because, if they have a smoking history, they might be doing lung cancer screening, not the best imaging for interstitial lung disease. But usually, to save cost, time, radiation exposure, we're not doing as many CT scans as I know my colleagues are doing. But if they do show progression of disease that you can visually see on the scan, that is concerning for a progressive phenotype. And you need to have two of those issues, either worsening symptoms and lung function symptoms and CT imaging, or PFTs and radiology are worsening. So this is just an example of worsening disease. So this is a patient with IPF. Again, you can kind of see at the bottom, so right lung, left lung, diaphragm, left diaphragm. And we are seeing this coarsening here at the bottom, kind of a honeycombish-like appearance, and it's kind of creeping up the edges here and into the fissure, this right fissure here. We can see it's very coarse. I mean, usually the fissures are pretty smooth. We can identify them, but they shouldn't really stand out at you. But this fissure definitely is very thickened here. And then again, just looks very rough on your way up. This looks nice and smooth at the very top, very nice and smooth. But we would call this reticulation happening in these areas, and mainly basilar predominant. This patient, 4 years later, now look how, I don't know if you can appreciate how far back you are, but how rough this lung now looks. This fissure is getting even thicker, thicker here, extending out. Now even some honeycombing happening in the left lower lung that we didn't see previously. And again, very coarse on our imaging here as well. All right, exacerbations. So when do we use oral corticosteroids? We tend to use them when they acutely exacerbate. Depending on what's driving the interstitial lung disease, oftentimes we may start them initially on a prolonged course of oral corticosteroids. And if we can't wean them off or they're continuing to progress, we will add on a steroid-sparing therapy, some sort of immune modulator. Then we try to wean the prednisone or the oral corticosteroid off, and because of all the long-term side effects of oral corticosteroids. Oftentimes if they're seeing rheumatology and the rheumatologist wants them to be on steroids, I'm like, I don't have to prescribe it, but you're still getting it and you're getting some benefit. Oftentimes patients do feel better on them. We tend to use them very sparingly in these patients. Patients who have purely fibrotic disease don't tend to really respond to them very well unless they're having an acute exacerbation, and even then response is pretty low. We don't usually use it as maintenance therapy. Again, we try to give them something else that is steroid sparing. When we do combine it with some other therapies, before we had antifibrotic therapies, a lot of our trials were showing more harm than good, and actually less survival in patients who were on long-term oral corticosteroids, especially azathioprine. So early on, patients did have benefit in the combination of oral corticosteroids with azathioprine. Probably, my guess is that they were getting a lot of the acute inflammation down, and that's why patients were initially doing better. However, they stopped the trial early because patients were dying faster in the treatment arm than they were in the placebo arm. And so we try not to combine those. Cyclophosphamide and mycophenolate are therapies that we definitely consider in these patients. Then in 2015, antifibrotics came to the US. It was great. We're all waiting for them. They came, we started patients on them. The very first one to market was pirfenidone. It is a pleiotropic antifibrotic agent. It goes after that TGF beta that I showed you kind of circulating there, and TNF alpha, and it inhibits the fibroblast proliferation and collagen synthesis that's happening in that interstitium. It got approved for IPF and IPF only. They did not go back for any other trials. And you start at 267 milligrams 3 times a day. You go to 2 tabs 3 times a day. You go to 3 tabs 3 times a day. And then you can transfer them over to the 801 milligram tablet, which looks like an augmentin pill. I mean, it's really big. 3 times a day. These patients have a lot of GI side effects. The adverse effects listed here is the photosensitivity, like getting sunburn in the car, nausea, vomiting, anorexia, and dyspepsia, and dizziness. Crippling fatigue was also something that was often mentioned post-analysis. A lot of patients had this just crippling fatigue. They couldn't get out of bed. That was seen with pirfenidone as well. GI side effects are very difficult with these antifibrotic therapies. It says with food 3 times a day. It should say with protein 3 times a day, because not all foods get along with these patients. Protein does seem to help. Something I learned from Ms. Corey Fratelli, who's going to be talking to you guys later, is sandwiching protein. So eating some protein, take your antifibrotic, eat some more protein. So let's kind of surround that pill with as much protein as possible. And I've had some great success thanks to Corey with that one. This is the capacity trial, one of the trials that did help get this therapy approved by the FDA. It was a 72-week trial, which is a little longer than what we normally see. A lot of our pulmonary trials are like 52 weeks, 24 to 52 weeks, so it was nice to have a 72-week trial, and did show benefit in controlling progression-free survival in these patients. The ASCEND trial was another pivotal trial for pirfenidone to get it to market, showing improvement in decrease of their functional forced vital capacity and or death in these patients. And the patients who were getting the therapeutic arm did better than the patients who were getting placebo plus whatever their background therapy was. Then came nintedanib, and it is a tyrosine kinase inhibitor targeting therapy, also antifibrotic is what we kind of group it as. It goes after VEGF, it goes after FGF, and PDGF for these patients. So it does work different than pirfenidone does, but still kind of clumped into the antifibrotic family. It initially had its approval for IPF, went back and got approval for progressive fibrotic disease as well. And in their trials, they did include a lot of patients with connective tissue-related diseases, which was very great for us to see because we had so many patients that were like, not all of our patients are IPF. You know, we'd love to start our other fibrotic patients on these therapies. It's 150 twice a day, which is nice. So it's not 3 times a day. So they have 100 and 150 milligram dose. Same types of GI side effects in these patients. Decreased appetite. There was a little bit of a signal for bleeding in the trial as well. And so sometimes we have discussion about stopping therapy before surgery or not. For the most part, the consensus, most people are not stopping these patients. We're not having like diffuse bleeding issues, but just something that patients might come across in their reading to talk to them about. Impulsus was one of the trials, one of the 2 trials that looked at these patients. They had to have IPF for at least 5 years coming into the trial. Their FVC had to be greater than 50%, and 80s considered normal, 80 or above of what's predicted for that patient. Their DLCO was between 30 and 10%, which is pretty severe. And then again, normal is 80 in that range. And then these patients were on concomitant prednisone. Less than or equal to 15 milligrams a day was allowed if they were stable. Coming in, a lot of the patients were not on steroids, but some of them were because, again, we had nothing better to offer them, at the time, a lot of the time. Secondary outcome for this was looking at time to first acute exacerbation. So they were able to show that they were able to slow the rate of decline in their FVC in the treatment arm versus the placebo arm. They were able to reduce also time to first exacerbation in comparison to the placebo group. And they had Impulsus 1 and Impulsus 2 trials, and they did not find a difference in those cohorts, so it was reproducible. All right, InBuild was another trial. It was a phase 3 randomized controlled trial looking at nintedanib compared to placebo. They had about 663 patients in there. They looked at progression of fibrosis on their high-resolution CT imaging, which, by the way, if you're going to order a CT, it better be high-res. Okay, just saying, you're going to make Pulm cranky if you send them over with like a chest X-ray. Like, we'll take it and we'll order the high-res, but if you're going to order a CT scan, make it worth a while. Do a high-res CT. So they looked at these patients that had non-IPF diagnosis that were enrolled in this trial, and this is the breakdown of who was in the trial that did not have IPF. So this was a great study for us to kind of see the patients that we were hoping to start treating with antifibrotic therapies that did not fall in that IPF arm. They did show significant reduction in decline of FVC in these patients. There was no difference in the patient symptom or acute exacerbations or mortality. And then there was increased rates of GI side effects in the patients and transaminase. So this is where we start watching LFTs, which a lot of times you guys are looking at with some of their therapies anyway. And then there was some similar efficacy between pirfenidone and the nintedanib group as well. And so these patients' decision of, not the patient's decision, but the provider's decision of which antifibrotic do we start on the patient, kind of that door opened a little wider when we said, well, this therapy is actually approved for everything else that is progressive and fibrotic outside of IPF. So we can use it for IPF, we can use it for fibrotic diseases that appear progressive that are not IPF, versus pirfenidone still only is technically approved for IPF. New therapies that are coming, nerandomilast looks like it's going to be approved. The phase 3 data was recently released and looks very good, so likely this is going to be coming to market. It is a phosphodiesterase 4B inhibitor. It is also having antifibrotic effects and immune modulatory effects on patients. It's twice a day dosing, and the 2 trials that we got some information out of was Fibronir IPF and Fibronir ILD. So they looked at patients that for 52 weeks, they were randomized either to 18 milligrams twice a day, 9 milligrams twice a day, or placebo plus whatever background therapy they were on. And then they took patients with DLCOs 25% or greater and the forced vital capacity of 45%, or greater than 45%. And they had to have stable antifibrotic therapy at least 12 weeks before coming in. And then they also looked at the efficacy of changing their FVC from baseline. So were they able to slow it down still, this disease, or stabilize their FVC, time to acute exacerbation, hospitalization, or death. And then they were looking at safety side effects that were reported, such as vasculitis, depression, and suicidality. So what they, as far as like the patient population that was in it, about 27% of those patients were the autoimmune phenotype of patients. So they took up a good portion of the patients in there. And then I don't know if you can read that from that far away, but the teal color is hypersensitivity pneumonitis, unclassifiable. Again, we have a lot of unclassifiable interstitial lung diseases. We're not quite sure what it is. And then idiopathic, non-specific interstitial pneumonias, and then other were in there as well. So looking at the results, oh my gosh, this is so tiny on my screen. I don't know how you guys are going to see it. This is some of the data looking at, oh, I should even wear my glasses. So change from baseline in forced vital capacity in the patients. They were able to show this is decline in lung function over time. And so the arms that were getting therapy did better than the placebo arm. You can see they lost more forced vital capacity here. This is patients taking background nintedanib therapy and how they did with their lung function. So this, I believe, was monotherapy, if I'm reading it right with my squinty eyes. And then this is patients who were on background antifibrotics coming in. So nerandomilast was added to it. This is patients taking background antifibrotic therapy here, and then this one is one's on pirfenidone specifically, and how they did as far as loss of lung function. This is the high dose arm, the dark blue. The patient's getting 18 milligrams, and then this is the low dose arm, which is the 9 milligrams, and then this is the placebo arm here, plus their background therapy. All right. This is change in FVC over 52 weeks overall trial population. So this is kind of the pooled analysis, everybody that was in the trial based on whatever they were on, no specific therapy. And again, high dose arm here, low dose arm here, and placebo group here. And this is change in their baseline FVC. This is patients taking nerandomilast, the monotherapy, I think, background, oh no, nintedanib, sorry, background nintedanib, high arm, low arm, and placebo group, change from their baseline FVC. And then this is change in FVC on patients taking nintedanib. One must be Fibronir I don't know, I need help from BI on this one. Hard to read those, what exactly they are, but looking at the curve of what's favoring the neanderthal group versus if they cross this line, it's favoring placebo. So there was separation in these therapies in all groups there. All right. Side effects as far as safety. So if you're seeing patients in your clinic that have been started on the new antifibrotic therapy, we're still having some GI side effects with this therapy. You know, it seems to be a little lower than what we saw with the other antifibrotics, which is nice, but there still was higher than placebo group. Coughing, which is a very common symptom of IPF, was reported in the placebo group, but was higher in the treatment arms. COVID-19 had to be reported during the trials, was a little higher in this group here. I think this is supposed to be the 9 and the 18, but they actually put 9 for both of them. Dyspnea, again, these patients tend to be dyspneic anyway, but was different than placebo, where the treatment arms had less dyspnea than the placebo arm there. Nasopharyngitis was actually higher in the placebo arm as well. This is the Fibroneer IPF, this is the Fibroneer ILD study. So this was the patients who had other progressive phenotypes outside of IPF. Again, same kind of similar profile of symptoms and side effects. Nothing was kind of shocking there. All right, some other emerging therapies that we might be seeing come out over the next year or two are listed here. So there's a couple phase 2 trials going on. You know, we start to wait for phase 3 to kind of give us a little more information on efficacy, safety, and side effects that patients are likely to encounter. And these patients, it's another BID therapy, which is nice. So not the 3-time-a-day therapy is so hard for patients to be compliant with anyway, especially when it gives them a lot of GI side effects. Here's another therapy. I'm going to try to get through these pretty quickly because I know we have to get to our breakout groups. Treprostinil, we've been using for group 1 pulmonary hypertension. It was one of our first drugs to get approved for group 3 for patients who had ILD-associated pulmonary hypertension, and now is being looked at for pulmonary fibrosis patients outside of having pulmonary hypertension. So this will be its first indication outside of pulmonary hypertension, which is pretty exciting. Some of their data was released pretty recently, and there's going to be some more data released here soon at CHEST. The INCREASE trial and the TETON trial, the 2 trials, if you want to look those up, that talk about their data and some benefits that we might be seeing. There's been other inhaled therapies tried for interstitial lung disease that unfortunately have been negative studies, but this one has given us some hope. All right, other emergent therapies are combination therapies that are likely to be coming out in the next 5 years. A lot of different mechanism of actions coming, so more to come. You'll be hearing lots from your pulmonary cohorts there. As far as multidisciplinary, I'm going to hand over to Wendy.
So a multidisciplinary role in rheumatology, we know, Corinne's done a great job of going through, where we fall with rheumatology, what we have to pay attention to, our patients with rheumatoid arthritis, medicines that we have them on, the systemic sclerosis, and how are we going to communicate with them. So I did start multidisciplinary discussions in my clinic, as well as combining with our pulmonology groups in Wilmington. And we have a thoracic radiologist that we work with as well. We have, I guess, 2 hours away, the closest, Dr. Morrison at Duke, who's a pulmonologist, and sets us up with his patients that it takes too long for them to get to a clinic. We're recognizing the patients at risk for the comorbidities with the interstitial lung disease, the screening, the systemic autoimmune rheumatology disease, and recommending any additional assays that they need to do. Recommended therapies, assisting with acute flare management, and maintenance of therapy selection. Selective autoimmune rheumatology diseases are associated with about 25% of ILD cases that have been identified. We can see the diffuse cutaneous systemic sclerosis, idiopathic inflammatory myopathy, Sjogren's syndrome, rheumatoid arthritis, and lupus. And really what the importance of this session today is really for us to see, and there's a lot on this slide, is what is our Rheum-pulmonary connection with regards mortality. As Corinne had said, time is long, and we can see with our disease states, whether it's rheumatoid arthritis, lupus, polymyositis, dermatomyositis, systemic sclerosis, Sjogren's syndrome, where ILD will fit in there as well. So monitoring our patients for acute exacerbations, following them, and we see what ILD and pulmonology clinics run into with their patients with either septicemia, hypertension, other comorbidities. So the goal, again, of the slide is really to make it a point that our rheumatology patients can die of ILD-related causes much more frequently than the general population. So it's just important that we are able to monitor any of those patients for acute exacerbations. I'm going to let Corinne finish up. Thanks.
No problem. Okay, so ACR came out with a great screening guideline for patients looking at their PFTs and high-resolution CTs. For those of you that, just in case you don't know much about CTs, high resolution, what makes it different is that 20 years ago when I started, we actually had film with CT cuts that we'd look at on like a light board. But we, back then, they would take 5 millimeter slices of lung tissue, whereas high resolution imaging now goes down to 1.25, and some of them are 0.65 millimeter slices of lung tissue, so it's very fine. We can see very early disease earlier in those high resolution CT images. They also prone your patients during that study because there can be a lot of dependent atelectasis, especially in obese patients. So we'll see this peripheral, is it atelectasis, is it interstitial lung disease, we're not quite sure, and then we prone them, and when the lungs kind of fall forward, it kind of straightens out and looks clear, or it doesn't, and we know this really is an interstitial process happening. So just so you know, that's a difference between high resolution and regular imaging in those patients. They don't need contrast with it unless we're looking at pulmonary arteries or lymph nodes or something else along those lines. So also you want to make sure your patients can prone. We have some patients that can't do that. We'll settle for a non-prone but still high resolution with fine imaging. All right. These patients may get a bronchoscopy, but again, only if we're suspecting underlying infection, especially if you all have put them on a lot of immune suppressive therapies and now we think they've got a fungal infection or something weird. 6-minute walk, we watch over time to see if these patients are able to maintain their walk distance or if it's starting to decline. Musculoskeletal joint issues are going to get in the way of our 6-minute walk being a valid test for us to use. If their body is giving out before their lungs do, that's not a very useful test for us, but if they are able to ambulate, that's something we try to measure. Again, biopsy is recommended against, but may be pursued if our imaging is, again, we just need more information before we can really definitively say what's going on with that patient, but we do try to avoid it nowadays because now we have therapies that are approved for progressive fibrotic phenotypes, right? It doesn't matter what's causing that fibrosis, we have therapies approved, so we no longer need a biopsy to find out what it is. All right, so this disease, we usually trend their pulmonary function testing, usually every 3 months. If they've been stable for a year or two, they are not showing a progressive phenotype, we likely are going to reduce the frequency of their lung function testing. But oftentimes we are doing lung function every 3 months. So if you are trying to hold out and manage and pretend to be a pulmonologist while you're waiting for them to get in, right, into a pulmonary practice, you can at least start ordering the serial imaging until they can get in and serial lung function tests those patients. We want to make sure that we're looking for desaturations in their oxygen levels, and oftentimes you're going to find it first with ambulation. Oftentimes at rest, unless they're obese, we're not usually going to see that, but with ambulation, we're likely to see it first. And then with high-res CT, you want to reorder that if we are seeing decline in their lung function or they're having worsening symptoms. And those symptoms aren't always dyspnea. Sometimes it's cough, a dry, hacking cough. Sometimes they may try to excuse it as allergies or postnasal drip or something else, and it might be, but oftentimes it is because they're having progression of disease. With patients who have a history of RA-ILD, or any of these other connective tissue disorders, the pulmonary function test again stays the same every 3 months or so, depending on how they're doing, how they're progressing or stabilizing, and then checking their ambulatory desaturation tests and high-res CT just like before. So these patients have a diagnosis of clinical ILD. If there's overt symptoms, we can see it on their high-res imaging, or their lung function is declining, is less than 80. 80 is considered normal. Or they have subclinical evidence of ILD because they have, no overt symptoms, but they do have some radiographic imaging that's making us concerned for ILD, and their lung function still preserved. But we're like, you feel like you're an interstitial lung disease patient based on your lung imaging going on, because sometimes they are not symptomatic until disease is progressed. Are you guys familiar with this ACR? I see a lot of heads shaking. Okay, I won't spend a whole lot of time here, but it's talking about first-line therapy based on systemic sclerosis, myositis, multi-connective tissue disease, rheumatoid, and Sjogren's, and what first-line therapies are recommended and when glucocorticosteroids are recommended in these patients. For cyclophosphamide, when we're giving that to patients, I know a lot of times in pulmonary, when we're using this, like with vasculitis, we prefer to do infusions. I'm sure in rheumatology the same. Oral therapies, we did see higher bladder cancers and some other issues. So I want to be very careful with that as far as safety, efficacy, monitoring labs over time with these patients. And then with mycophenolate, there was this subgroup analysis of patients with mycophenolate did show improvement in their predicted forced vital capacity, who also had overlapping interstitial lung disease. Rituximab, this is a phase 2 randomized controlled trial looking at rituximab with cyclophosphamide together. They looked at patients with different types of autoimmune-related lung diseases with interstitial process. They found no difference in the change of their forced vital capacity from baseline. Both patients actually had an improvement in their FVC at 24 weeks, so they were efficacious there, non-superior to each other. As far as rituximab, there's another EVER-ILD study looking at, again, patients with SARD-ILD, idiopathic interstitial pneumonias. Those are the COP, BOOP, ones that we talked about, organizing pneumonia, NSIP, and they looked at these patients with high-risk, that were diagnosed by high-risk CT, and then they looked at them with combination therapies, followed them for 6 months, and they were looking at the change in their FVC over time based on the combination therapies that they were on. Azanthropine, there is very low evidence for azanthropine right now to be beneficial in these patients. There are some small open label prospective trials going on. They're not randomized. And right now, guideline is just saying based on your clinical experience and considering it as an alternative therapy for your patients with SSc-ILD. But there's, again, not very hard evidence with that right now. As far as escalating therapy in your patients, if there is evidence of your patient is having progressive phenotype based on their symptoms, their CT imaging, or their lung function, that's when we want to start talking about being more aggressive. We already talked about the progressive phenotype with the decrease in their FVC, forgive the one there, by greater than 5%, with increasing fibrosis on high-res CT, or declining of the, I think that's supposed to be the DLCO, yeah, of 10%. So forgive the typos there. All right, I think we covered this. How are we doing on time? Does anybody have time? Okay, so we'll rush through these real quick so we can get to our breakouts and stand up and not hear me talk anymore. Here's an tentative trial looking at patients with diffuse cutaneous disease, of patients that were receiving background mycophenolate at baseline on a tentative therapy that we talked about. Systemic sclerosis. One of my work partners is here. She has a patient right now that has been diagnosed in the pulmonary clinic with systemic sclerosis. She hasn't seen rheumatology yet and was told she can't be seen by rheumatology because we weren't part of their system. It was kind of very interesting. So if anybody wants to see her while they're here, it'd be great. So they looked at patients with systemic sclerosis associated ILD. These patients, up to 80% of them, these scleroderma patients have radiological evidence of ILD. So these are very high red flag patients that you want to be screening, listening for those crackles, and you better put that stethoscope on skin because you put it on clothing, you're going to hear crackles or you may even miss them. You got a guy with a hairy back, it's going to rub up against their clothes and sometimes sound like crackles when it's not. So make sure you put it on skin, listen in the bases. That's a lot of times where you're going to find it. 30-40% of these patients do end up developing a symptomatic ILD, and they have about a 10-year mortality of approximately 40%, unfortunately. It tends to be higher in African Americans and males, and the patients who have diffuse skin disease on top of it tend to have worsening outcomes and development of disease. Findings associated with that, I don't think I need to lecture you on this one unless you want to go into...
Yeah, you can go.
Okay, do you guys all feel pretty good with SSC? Do I need to mansplain from a pulmonary standpoint what this is? Okay, all right. Do I need to give you the pathophys on SSC? Okay, I'm seeing shaking of heads, no. All right, looking at treating this disease, we want to avoid corticosteroids if possible due to the risk of renal crisis. Again, I don't think any of this is new to you guys either. Nintedanib is the only guideline recommended therapy for antifibrotics in these ILD patients. All right, patients with myopathies associated with ILD, we don't like these in pulmonary. They always scare us when we start seeing these patients. I would say the scleroderma patients are probably actually worse because they start aspirating and then we're like, we feel totally helpless. But these patients with polymyositis and dermatomyositis patients, approximately 19 to 42% of them develop ILD, and they have a very high mortality rate, unfortunately, and oftentimes they end up in the hospital, and oftentimes, unfortunately succumb to this disease. Do I need to go over physical findings? You guys feel pretty comfortable with this? Again, from a pulmonary standpoint, I don't have to tell you what labs to look for. All right, treatments, RA. There was a small cohort of the pirfenidone group for RA-ILD before the progressive fibrotic phenotype studies started, and it did show some benefit in those patients who had a UIP pattern on their CT imaging but had underlying rheumatoid arthritis. But the other therapy, nintedanib, is also approved for all the autoimmune-related progressive fibrotic phenotypes. Some end-stage therapies, the stem cell transplants, very limited information there. We do see a lot of our patients, unfortunately, spending their whole life savings going to other countries to get stem cell therapies, that are kind of promised to them. There's even some companies called the Lung Institute, and it's podiatrists and pediatricians running it that are not pulmonologists, offering them stem cell therapy. So I always tell patients to be very careful. But the hematopoietic stem cells are if they're going to do those types of therapies, that's the only area that we have very minimal research in. Lung transplant, absolutely, these patients need to transplant sooner than you think they do. So always want to make sure they get a referral very early. It's very difficult, especially with underlying autoimmune, and especially if they've got scleroderma, because of the dysmotility issues that we have with those patients. And a lot of times they get denied their perfect candidate outside of their achalasia or whatever's happening because they don't want to risk aspiration post-transplant. Do you want to take some more multidisciplinary?
You can.
Okay. I think she covered this very well. Wendy did, just making sure we're getting pulm and GI and rheum and everybody together to make sure that we're managing these patients very closely. Sometimes cardiology even involved. If your pulmonologist is not managing the pulmonary hypertension side, your cardiology team likely is. These patients tend to overlap a lot of disease states. These diseases don't happen in a silo. Yeah. They like to happen together and run in packs, like she said. Also talking very early about palliative care and hospice should happen earlier before they need hospice. That discussion should happen. All right, so overview, very difficult population, oftentimes difficult to diagnose in the early stages. Can progress, unfortunately, has a very high morbidity and mortality. prognosis, can mitigate further fibrotic changes other places in the body. We want to try to preserve their status, preserve their lung function as long as possible. New therapies are coming. We have new established therapies, which are great. And we want to make sure that we're getting them into multi-specialty cares and also talking about what is their goal. Because a lot of these patients, their goal may not be to even treat it. They're happy. Because some of these patients, a lot of these patients with ILD are like 80 and 90. And they're like, I got to die of something. I feel pretty good right now. Just make me comfortable. And so those are the patients we make sure we're meeting their goals. And that's where palliative care definitely helps if you don't have the time to speak with them.